Attendees are in listen-only mode.
Welcome to the Essential Substance Abuse Skills webinar series. Today our webinar is Professional Readiness, Attitudes, and Values, and it will be presented by Bob Rarrett. I'm Karen Summers, and I'll be administering today's webinar. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. The National American Indian and Alaska Native ATTC is one of 4 national focus centers which serves the ATTC network. The ATTC network is a nationwide network made up of 10 regional centers, 4 national focus centers, and a network coordinating office. The map on this slide shows the states served by each of the regional ATTCs. To learn more about our center, the network, or your regional center, please visit our website. This series is designed to be a broad overview to assist in preparing for our written alcohol and drug certification exams, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. We recommend that if you are preparing for an exam that you seek additional preparatory help, and let this course be one of many tools you use to prepare. Our next webinar in this series is scheduled for Wednesday, October 16th, and it will cover group counseling. In addition to this webinar series, we offer another series titled the American Indian and Alaska Native Behavioral Health Webinar Series, which presents on current topics of interest in the behavioral health field. The next session in our American Indian and Alaska Native Behavioral Health Webinar Series will be held on October 2nd from 1 to 2 p.m. Eastern Time, where Peter Nathan will present from DSM-4 to DSM-5, Significant Changes for Substance Abuse Professionals. For more information on our webinar series, you can contact me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs. The cost is $10 to do so. The CEU request form, along with a copy of the PowerPoint, will be sent to you within 24 hours of today's session. If you don't receive the email with the handouts within 2 business days, please let us know. In addition to the PowerPoint handout and CEU request form, a link to our GIPRA evaluation will be included in the email you receive following today's webinar. We invite you to participate in this brief online customer survey. The survey asks about your satisfaction with the event and will take less than 10 minutes to complete. GIPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. SAMHSA uses the information collected by these surveys to determine how many people have attended our events, your satisfaction with our events, and how useful our events are to you. We hope you will assist us in gathering information about our services by participating in our evaluation. Before we start today's session, I'd like to give you a quick overview of the GoToWebinar system. To hide or expand your toolbar at any time, you can click on the red arrow on the top right-hand side of your window. To expand your screen, click the middle button in the top right-hand corner. You will be muted for the duration of this webinar. Please use the question chat box to share your questions and comments. Your questions will only be visible to me, the webinar moderator, and I will pass your questions along to the presenter at appropriate points in the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEUs received. Today's speaker is Bob Rarrett. Mr. Rarrett has worked in the field of behavioral health for 20 years. He is has been internationally certified through IC&RC and is currently employed by Ramsey County Human Services as the director of a 50-bed medically monitored detoxification center in St. Paul, Minnesota. Bob has experience as a clinician, clinical supervisor, senior manager, director and executive director in a variety of settings. Please join me in welcoming Bob Rarrett.
Good afternoon, everyone. Thanks, Karen. Let me put this in a slideshow. Thanks for joining me this afternoon for about an hour to talk about professional readiness, attitudes, and values. It's a broad topic, and we'll cover, I think, a few of the important aspects of this topic for you. I welcome any questions toward the end there that I can clarify or add to anything that I've said during the presentation. Let me move through this. I should have had this ready to go. Okay, so the goals and objectives this afternoon have to do with these 9 topics. Again, we'll touch primarily on professional readiness, ethics, some supervision, and the rest of these goals and varying degrees. It's going to be kind of a, like I said, a broad overview with my usual editorials. So there are a lot of behavioral health theories out there. There are probably about 12 to 15 that have some evidence behind them, and they're commonly used in the field. To find some common themes between these therapeutic or behavioral health theories, we looked at approximately four things to focus on. One being the therapeutic relationship that's common throughout the various theories that are out there. To me, the therapeutic relationship is, whoops, what just happened? Bear with me here, there seems to be a issue. Okay. The therapeutic relationship to me is the key factor as to whether or not a client decides to make changes in their lives. Without that, I think it's a struggle, it's an uphill battle to get anything accomplished. The other common elements of behavioral theories have to do with cognitive insight, emotions, or affective experience, and appropriate client expectations. The client right to know, or the client's, I should say, informed consent is important. We have to let them know what options are available to them, even if it's not options that we provide as a program or as an organization, and make sure the client is informed of all of the treatments available to them, even if it's not in line with our own philosophy or our own beliefs about what would be helpful to them. Now, this was taken from Walburn. It's a rather dated text from 1996, but it looked at reasons why people enter the helping profession or the counseling field. Other than the number one thing, to help other people, the other two things kind of scare me a little. I firmly believe that the reasons for entering this field, if we're to truly help other people, we have to have our own house in order, so to speak. So to enter this kind of a profession in order to satisfy personal needs, or because we're lonely or need something to do, those last two reasons might be a little worrisome. As those of you who have been in the field longer know, primarily we have to be objective. We have to focus on the client's needs, and certainly not draw our own personal needs into the equation. So there's just a simple exercise that I think all of us should do from time to time. If you're new to the field, maybe a way to evaluate sort of your reasoning behind getting into the field. A way to do that is to ask these questions of yourself. List reasons why you've entered the field at the time you began your professional experience, how your reasons for entering the field have changed over time, and then do you feel you're being supported, or the reasons you entered the field are being supported, and if so, by who and what is their motive. I think most of us enter the field primarily for the same reason. It's our desire to help other individuals attain a better level of health. And oftentimes we enter naively thinking it's going to be just about sitting down and meeting with a client, having this wonderful exchange that results in epiphanies for the client. And oftentimes as we stay in the field longer, we realize it's not that simple. There's a tremendous amount of paperwork. There's a tremendous amount of, there are tremendously complicated clients that have a variety of needs that are almost overwhelming when looked at as a whole. And it becomes sort of ambiguous, or maybe just our vision of what we thought was going to be the job turned out to be something different. The bureaucracy involved, and I can speak from experience working in government, that there's a tremendous amount of bureaucracy involved sometimes that act as barriers to getting clients what they need, even when you know that's what they need. But I think that the challenge to any professional in this field is to step back from time to time and say, you know, it's part of my responsibility to help change those things. It's part of my responsibility as a professional in the behavioral health field or as a counselor to look at those barriers and find a way to address them. If nothing else, to advocate for our clients and to improve the system of care that we're currently working in. A lot of that's happening through the efforts afforded by the ACA, the passing of the Affordable Care Act, and local state efforts and county efforts, organizational efforts to develop more whole person-centered care and breaking down some of these barriers that have existed for a long time to meeting client needs. But these are things that you come across as you evolve through your professional, the course of your career. These kinds of things become more apparent, and it's easy, honestly, to become jaded, to become sort of convinced that, oh, the system will never change. And those kinds of feelings can really lead to questioning whether or not a person should have gotten into this field, whether or not I should have, whether this is meeting the needs that I thought it was going to meet, this type of work, etc. So I think it's a natural evolution for most clinicians in this field to start out very enthusiastic, over time kind of question how things are working, and then decide at some point, is there something am I going to do something about this? Am I going to make the best of what I have to work with here, or is this not for me? You know, is this field not for me? Most people, if they're healthy and centered on the client, will remain in the field and find a way to be to contribute to the ever-evolving healthcare changes and find ways to benefit our clients. One of the considerations for anyone entering this field is ethics, and again, it almost goes back to the reason for entering the field. What is my reason for wanting to do this kind of work? And I think ethically there's a standard that should be met that says my needs are not the focus here, it's the client's needs. And my intention, regardless of what kind of gray areas I enter into ethically, my intention should be to do no harm to the client. And ethics essentially is the professional guidelines that allow us to practice professionally and within a framework to protect our clients as well as ourselves. So ethical conduct is not just a matter of making sure that clients' needs are met, but it's protecting yourself from lawsuits. It's protecting yourself from potentially gray areas of practice where you or your organization could be held accountable for decisions you make. I think, just though, to put your minds at ease a little bit, I think as long as you do what you think is in the best interest of the client and your intention is to do no harm, generally speaking, that's the moral compass to follow here, and that's generally a safe path to follow. There are different kinds of ethics. There are mandatory ethics, which are basically laws or policies that guide our behavior as clinicians and which have to be followed regardless of what your personal ideals might be. Aspirational ethics are more a reflection of the situational welfare of the client and the effects of the counselor actions. That's a little vague, but I think aspirational ethics are more in line with those situations where the law or the client's circumstances are not especially clear, and you have to make a decision one way or the other as to how to move forward. That's usually the best time to seek out clinical supervision. A little bit of advice on that. If you're not sure, ask somebody else and get some professional guidance from someone you trust in your organization or somebody that you report to. Ethical principles, autonomy. People have the right to choose what's in their best interest. I think that's sometimes affected, especially with substance use disorders or co-occurring disorders, where a person may not have that ability sometimes to make choices that are in their best interest. But still, the individual, the client, does have that right, and we should always make decisions based on collaboration with the client to work in the direction that they want to go. Certainly do no harm is the primary thing, and the counselor's responsibility is also to find ways to do good to better the client's situation. Social justice issues are important, advocating for clients who maybe have a sense of inequality, either for a variety of reasons. It could be anything from ethnicity, race, culture, to social or to economic inequality. But we have to be the advocates for clients to make sure they get equal treatment. And then fidelity, just loyalty and faithfulness, honoring commitments. Integrity can't be overstated in the client relationship. If you say you're going to do something, then do it. And no surprises is the ultimate goal. You want the client to be well informed, and you want to follow through with the things that you say you're going to do. Or inform the client if you've tried something and it didn't work out. In any case, be upfront with them. Decision making. Ethical responsibility, as it says, is to learn and adopt a decision-making model and utilize it. Supplementing what's in the law, that is what's required of you as a clinician and a professional in this field. Don't step over that line and know where that line is, but also supplement with through clinical supervision, through experience, ethical decision-making models that match sometimes the gray areas. So in other words, if you come across consistently a situation where you're not sure ethically what the right thing to do is, first consult, and if there's a process that you can follow as a clinician that makes sure you're adhering to laws, making sure you're adhering to the professional judgment of others in your organization, and then following essentially what is in the best interest of the client. A model along those lines that you consistently work through when making ethical decisions. In other words, have a structure, a framework, something that you rely on as a way to make decisions ethically. And there's an example of a model. It's rather basic, but it does give you something to go on as you make decisions for client care. I think obtain consultation. That's the main thing. Don't feel as though you're alone, that you're making this decision and that could have consequences for the client. Don't feel like you're making those kinds of decisions on your own, but check with other people in your organization. Call a colleague. I've certainly done that over the years, and I've found that to really open the doors in terms of options available, and has helped me as a sort of a mirror reflect back some other options I might not have considered when I presented the problem to a colleague. And then develop a course of action collaboratively. Fact-finding, you certainly, when you're trying to make ethical decisions, you certainly want to have all the facts that you can get. You don't oftentimes, you never really want to just go by anecdotal statements or hearsay or your impression of the situation as a means of making an ethical decision. If that's all you have to go on, then that's all you have to go on. But in most cases, we have the time to at least find out the facts, verify a few things, and make sure that we're making it the best informed decision that we possibly can. And not basing those decisions on our personal moral values or on anything other than what's in the best interest of the client and the law and the agency requirements for your or the expectations for your behavior as a clinician. Again, the client-therapist relationship is of vital importance in therapy. I think we all know that. I think where it gets a little questionable sometimes as to is how that relationship develops. You certainly don't want to be a friend to the client, but you want to be empathetic and open and honest. The issue of self-disclosure comes up a lot. It's my personal belief that self-disclosure should, if used, should be used on a very limited basis and only when you think it's in the client's best interest, only when you think self-disclosing something about yourself would help the client move forward. I really don't think, after years of doing this, I really don't think that openly sharing a lot about yourself does much to help the client relationship. What it tends to do is it puts the focus on you and your issues and not so much on the client's. A professional relationship has to do with objectivity, thinking about what's in the best interest of the client, and ethical behavior. But objectivity and empathy primarily help you get through that. If your agency says that self-disclosure is okay, then you're free to do it. Again, my experience has been that when you have an organization where you have some recovering people and some who aren't in recovery, that by self-disclosing the fact that you're in recovery can sometimes create a barrier between you and the other counselors who are not in recovery. So staff splitting, essentially. So you have to watch how the clients respond to that sort of thing in addition to what your own beliefs might be. And again, ultimately, do no harm. That's the ultimate goal here, and hopefully to do some good in addition to that. The scope of practice has to do with understanding what our limits are, what our knowledge base is, and not going beyond that. Certainly, there's a variety of things that we do as a counselor in this profession. Case management, treatment planning, continuing care assessment. There's a lot of different things, and we can't be experts on all of them, or few people are anyway. I think, especially as you enter into this field, understand where your limits are and seek help when you go beyond those limits. If it has to do with, say, a medical condition or a mental health condition, and you're not as familiar with that, those areas of practice, and certainly you need to consult with somebody or refer the client on. I remember a comedian in the 1980s that said, I have a liberal arts degree, which means I know just enough about everything to be annoying. And I think sometimes you have to remember, we know a lot about all of this, or we know something about all of these things, but we may not be experts in each area, and there may be somebody more qualified to assist the client. And really, it shouldn't be an ego thing. It should just simply be, I understand where my limits are, and I want the best for this client, so I'm going to refer them to somebody who knows more than I do about it. Involving the family, community, really as the behavioral health profession evolves here, and we start looking at more whole person-centered care, involving anyone in that client's life that could be an asset to their recovery or their improved health. We should always make an effort to do that. I understand there are barriers sometimes with confidentiality. There are barriers sometimes just with getting others to get involved in the client's treatment. but the effort should be there. And there's a lot of different ways to involve various organizations to all work towards the same goal. Some of those ways involve technology like electronic health records, interactive websites, and things of that nature. Organizational agreements, things that are called quality service organization agreements that allow different organizations to communicate some confidential client information without individual consent. Those are things that we could look at as ways of extending what we do to the community and involving more professions, more professionals, and the client, of course, in the decision-making process as to how to best move forward and get them the help that they need. You're going to see, I think, a large a change come in the next couple of years with respect to how behavioral health is viewed and how treatment of people with substance use disorders is managed. I don't want to go off on a huge tangent here, but substance use disorders really appear to fall within the same class as any other chronic disease and require long-term ongoing support in various degrees. So if you think of it in this way, it's providing a dose of care to an individual, and that dose of care can come from a variety of different sources, and we have to look at all of those sources and what dose of care the person needs from each of those sources. Sorry for my little tangent there. Again, personal boundaries are part of professional conduct and remaining objective. It's easy to get drawn in to a client who's very amenable to change, somebody who's very easy to work with. And it's easy to get drawn in emotionally and become sort of attached to them. But I think to be effective, we have to keep our distance professionally and really recognize this is a person that needs our assistance, not somebody that needs us to become their friend. And if we become too emotionally attached to someone, obviously that affects their objectivity, and it can hurt the counseling relationship or hurt the client inadvertently. So the idea, again, is to really keep in mind whenever you're working with a client, keep in mind my role here is to remain objective, to do what's ethical, and to do what's in the best interest of the client. Giving the client choices should always be the case, but a person has to be allowed to make some decisions for themselves and not just walk into a counseling relationship and be told, here's what you need to do to get better. Generally speaking, that approach doesn't work very well, and the client has no buy-in to the whole change process if they're just told what to do. And none of us would really react very well to being told what to do. So it's common sense, I think. Set boundaries immediately. I think that what this is referring to is to establish the counseling relationship very clearly to the client so they understand what your role is, what your objective is, and what you're trying to do with them to make their situation better. Certainly don't make threats and false promises. I would hope that no one would do that in this profession. I'm sure it happens, but that's a pretty obvious thing to avoid. I think, though, historically in this field, that was fairly common. I think, again, the intentions were good, but certainly the threat of consequences or confronting clients in a way that maybe was threatening to them anyway was done more often than I care to think about in the past. As we move into now more motivational interviewing styles and motivational enhancement approaches that are strengths-based and look at a client's assets rather than their deficits, I think we make a lot of progress. We've made a lot of progress in this field towards minimizing that sort of thing, the threats and the false promises. But you're a role model for the client. They're going to look to you for guidance on how to behave. As Karen said in my introduction, I currently manage a 50-bed residential medically monitored detoxification center in St. Paul. And the clients are in a large common area where they can view the staff and view the staff's behavior and interactions. And it can't be stated enough that what the client's seeing us do, they'll respond to. The same goes for any professional counseling relationship. The client will look to us for guidance on how they should behave. Oftentimes this is, I think, because a lot of folks really haven't had good role models in their lives or mentors in their lives that have helped them establish what it means to express emotions in a certain way, or what it means to think through a situation and speak appropriately about another person. They really, and this is not a criticism of clients, but it's really a skill that I think needs to be developed in a lot of people. And they look to us for developing that skill. It's not going to be an obvious thing where they say, I watched you do this and therefore that's why I behave this way. But you'll see it in the interaction. You'll see the behavior of the client will be a reflection of your behavior and your enthusiasm, your hope, your realistic appraisal of what they can accomplish. And I think we have a great influence over clients' decisions to make better, clients to make better health decisions simply by virtue of how we interact with them. And that's really important, and it's really an important part of the professional relationship with a client. Again, not to give them false hope or give them unrealistic sorts of expectations, but to really help the client see that that recovery is possible, and there's certainly hope and support probably in their environment that they can utilize that maybe they haven't before. So how do counselors develop, generally speaking, through the course of their career? And I talked a little bit about this already, but this is based on some other textbooks that are referenced here. But counselors are seen, according to this source, counselors are seen to move through 3 levels of development. But there are usually brief regressions through the sort of after the honeymoon stage of the counseling profession, or after you begin your counseling career, and those regressions are oftentimes then offset by just more confidence and skill development. But primarily those levels consist of exuding trust and hope. We all enter the field with that enthusiasm. Like I said, we want to help people, and we believe that we can help people. And then there's a stage of confusion sometimes, striving for independence. You're no longer just following someone in your agency that you've respected or who has mentored you. Now you're off on your own, kind of developing your own style, your own skills, your own way of working with people. As it says here, you're less imitative, and sometimes during that stage there's a sense of instability or ambivalence. You're not sure, you're not confident enough in your skills, you're not confident enough in your approach. You're kind of waffling back and forth between, I think I can do this, but I'm not really sure. And you're also getting a sense of what's involved in counseling. Like I said, the paperwork, the bureaucracy sometimes. And it can all kind of come together after a while where you start to question, geez, should I have done this or not? Or am I capable of doing this? Am I as skilled as I need to be? Some of that self-assessment takes place. After that phase, and it's hard to say how long that phase will last, but after that phase, people generally start to come into themselves. They start to realize, okay, I do have the skills. I do have a style of my own that I can use to help benefit people coming to our agency or our organization. And it begins that process of then settling in and furthering your knowledge, furthering your expertise, and refining your abilities to even get better and better as time goes. I think the thing I would mention here as well is that the learning process and being open to different ways of approaching client care should always be there. You can't get to a point, in my mind, where you say to yourself, I know how to do this now, so I don't really need to learn anything else. I have met people like that, but I think it's very damaging to the client's care overall, because it limits what your abilities are, essentially. It limits what your toolkit is for helping clients. Like any other healthcare issue, behavioral health changes over time, just like medicine and approaches to medicine changes over time. As we become more knowledgeable, we look at research and we look at methods that have been proven to be more effective over time. Then we adjust our style to match those methods. We should always be striving to do what seems to be the most beneficial approach for our clients based on research, based on evidence, and based on the best available information that we have at the time, and always be willing to advance that knowledge and that openness to new approaches. We have to put our egos aside and always be in the learning mode for counseling and behavioral sciences. Supervision, as I've said, is a critical aspect of any counselor's position. You have to consult with a supervisor. If you don't agree or you have problems with your supervisor, then seek somebody else in your organization and explain that to them. But we really can't operate in a vacuum here, or we all end up doing our own thing, and it may not be in the best interest of the client. So again, our ethical obligation is to seek supervision and not just work under case evaluation. So you don't just show a file to a supervisor and say, have I done all my progress notes? Have I, is the treatment plan structured properly? But you really need to talk about decision making, the client's situation, as complex as they are, and how you would proceed under those situations, or get the supervisor's input on how they suggest you proceed. Without that, it's going to cause problems in your career, and it's going to really limit your knowledge base and your skill development, and it's unethical. So the 3 goals of an effective supervisor are to assure delivery of quality treatment, create a positive work environment, and develop staff clinical skills. A positive work environment can really be established by building that enthusiasm that sometimes waxes and wanes within an organization, but really I think constantly looking forward and saying there's some promising practices here, there's some new practices here that are evidence-based. Let's look at these, let's keep the counseling staff excited about their jobs and keep them invested in always finding better ways to do things. And I think that in and of itself can help with the positive work environment. If people get stagnant, they tend to get unhappy. Effective clinical supervisors are effective communicators, clearly describe the vision, what it is we would like to accomplish here as an organization. How do we intend to get there, and what's the benefit for the clients and the organization? Again, the same as with a client relationship, integrity, and providing clear and concise expectations for the clinicians involved or the whole staff involved. Where there's gaps in skill development, then we need to fill that with as much education as possible. I think oftentimes what we end up dealing with is brief workshops that touch on very complicated issues, and then we don't follow up with that. Motivational interviewing is an example of that. It's a more complicated skill than just being friendly to clients, and follow up with that through either longer-term trainings or as a program through developing a training agenda that continually builds upon previously presented information. But we have to be moving in a direction that's progressive always, and we have to get the staff to buy into that. So it's really a matter of, as a clinical supervisor, of giving a clear vision of where we're headed and helping them get there. It's also the last one, check assumptions about counselors. I think, again, I think not to assume that people all buy into this vision, but understanding that when you don't buy into the vision, maybe this isn't the place for you to work. If you've got a well thought out strategy and a way of doing things, then it becomes a matter of bringing people along with you in that quest. And it may not be a direction that all people want to go, and that's okay. But I think as an organization, there has to be a common goal for everyone, and those that don't agree with that goal can, go find a job where their beliefs are more understood. That sounded cold, but you know what I mean. I think the supervisory tasks and functions are administrative, evaluative, and clinical in nature. Supervisors have a variety of things they have to constantly keep track of. Some are administrative duties that take a good amount of time. And then evaluating service delivery to make sure that what you're doing as an organization is effective and has good outcomes. And then, of course, helping the clinicians develop clinical skills that are in line with approaches and behavioral health theories that are being utilized. Evaluation is critical. We have to make sure that what we're doing is working. And if it's not working, that's okay, but let's not do it anymore or find a way to improve it. Evaluation has to be an element of what we do, and we have to constantly, as supervisors, but also as clinicians, do a self-assessment of ourselves and our organizations that says, this is working based on these metrics, and this is not working. So let's look at why that is. The decision-making for ethical responsibilities involve, as I said, using your supervisor. Oftentimes, clinical supervision sessions, and I'm guilty of this as well, can be sometimes put off or not regularly scheduled. And I think really to be effective, they have to be something that you make time for. Individual consultations are certainly always necessary, but having a formal time that you sit down with clinicians and say, what problems are you experiencing, or what kinds of client situations are you trying to think through that regularly come up or that have come up that are interesting to talk about, and let's figure out how we would manage that or think about that. And the last statement on here is just what I've already said. It's not your decision to make a loan, nor should it be felt that it's your responsibility to come up with this solution on your own. That's the whole reason we have teams and have clinical supervisors and managers, is to help you with that. So I would hope wherever you work and whatever organization you work in, there are people that you can bring into the discussion so that you feel supported. I'm just going to talk briefly about transference and countertransference. I don't want to dwell on this too long. The definitions are here so you can revisit them. But transference is obviously when the client, I have to read it now that I've confused myself. The client's perceptions of a thing apply to the counselors. That is, they attach meaning to the counselor that may be a reflection of somebody else they knew in their lives or some other experience they have, and react accordingly. So the unconscious shifting of feelings and fantasies that are a reaction to significant others in the client's past. So the client may react to you differently simply because they connect you with another person in their lives or another experience in their lives or some other fantasy that connects somehow with your presence. Countertransference is the reverse, where the counselor has the same kind of reaction to the client, and that is something we all have to pay attention to so that we don't treat clients differently based on some perception that they are a certain way or they remind us of a certain person or a type of a person. And we have to always focus on objectivity in that case and not treat clients differently based on our own emotional reaction to them. The obligation of the addiction professional to participate in prevention as well as treatment. To me, there's a whole spectrum of care that we should always pay attention to. Again, substance use disorders are sometimes a very long-term disease that requires support at varying levels. Prevention has a very key role in either preventing the problem from getting worse, preventing the problem altogether, or once the problem's formed, helping to mitigate the damage that was done. There's a lot of things that go into that. I think funding for a long time has separated treatment from prevention, from aftercare services and that sort of thing. But really, we need to look at this all as a spectrum, and what kinds of things need to be talked about in a preventive way, what kinds of things need to be dealt with in a clinical way, and what kinds of ongoing support needs to happen. But all of those considerations should be made relatively at the same time or concurrently. So we're always thinking about how do we manage, how do we help the client manage their behavior in a way that prevents further damage to their lives or their health, and in a way that also treats them for current things that exist. There really shouldn't be a separation. Again, it's more of a spectrum of severity oftentimes. Prevention plays a key role in clients understanding more about their situation, more about what they can do to better their situation. And I think prevention too often has been defined in the past as we're going to prevent somebody from ever getting this problem, when really it sometimes is a matter of preventing it from the problem from getting worse or from becoming pathological or compulsive in some way. Biopsychosocial stress. This has to do with the counselor primarily, and what kinds of things as a clinician you need to pay attention to in order to remain healthy and be able to be the best provider that you can be for the client. Stress is a natural sort of issue to contend with in this field, obviously, because of the nature of the clients and the problems that they present with, and the nature of the workload that you're often presented with, and trying to manage all of that without, I can say stay objective and stay sort of detached from the emotional part of it, but really there's no way to do that completely. The toll that this position or this career can take on people is a real thing. It can affect your health. It can affect your desire to do this kind of work. It can affect all kinds of things in sometimes a subtle way. And we need to pay attention to our own stress and our own emotional well-being. Most organizations have access to an employee assistance program where you can get confidential counseling or assistance with issues like this. And I think it's an underutilized service, and I really think if you have an EAP and you're experiencing significant emotional stress or distress, that you seek out an EAP counselor. It's confidential. It's oftentimes or usually free, at least for a few sessions, and you can get some feedback on, is this something I need to pay more attention to, or is this something I need to get some help with? You have to stay healthy in order for your clients to benefit from your work. And these are just some ways in which stress can affect you. I think you're probably aware of most of these things, but some are biological and some are emotional manifestations. But the reality is that stress does affect your health, and in a physiological way as well as in an emotional, cognitive way. And again, we just have to pay attention to that as professionals and really monitor our own stress levels. I think talking with a clinical supervisor about stress can help us gauge sometimes, is this fairly normal to feel this way, or is it go beyond that, and what do I need to do to help myself here feel better? I'm just going to quickly review this, but it's symptoms of stress. I think, again, most of you would probably recognize these. But again, just to as a clinician, I think we have to be hypervigilant about paying attention to these particular signs and symptoms. Too often we write them off or feel like we should be able to handle them because we're in a counseling role, when in fact we're people just like everybody else and have to sometimes take care of ourselves. Burnout are terms used, I equate them with compassion fatigue, and it's varying degrees of what that compassion fatigue might look like. Again, here's some guidelines for just questions to ask yourself to help you judge, is this how am I experiencing this kind of thing? Does this sound like me? Having trouble sleeping, or I can't let work go at the end of the day, or whatever the case may be. But again, really talk to somebody in your organization if you feel like these sorts of things are going on with you. It's certainly understandable, again, given the nature of the work we do and the volume of the work that we do. This is just a definition of burnout, but most of us have heard the term. I prefer compassion fatigue. It sounds better, but essentially it's a state where if you get to this point, you really need to take some action, if not just for yourself, but for your clients that you're working with. I'm not going to focus too much on this. It's a general progression of burnout. It's a good definition here. It's sustained, unmanageable, and painful stress. And your response is your responsibility. And this just sort of reiterates what I just said. So what do you do about it other than talk to somebody at your organization or talk to an EAP counselor? You set your limits to what you think you can manage. Again, do this in collaboration with your organization, but let them know why you're struggling and what kinds of things you're struggling with. It's your duty to understand the process that you need to follow in order to get better. Do some research on your symptoms, all of those things. But it is your responsibility. And please don't brush it off as just, I should be able to deal with this kind of thing, because it does no one any good to do that, especially you. Time management can be a good way to help with stress. If you can sit down with your supervisor and go through your responsibilities and say, how do I manage my time given these different demands on it? Oftentimes that in and of itself can help relieve stress, simply because there's a framework from which to operate. You can say, I devote this much of my time to this much of my time to this, and it all equals 150% of your time. Then obviously you have to look at how you restructure your time, or more than that probably, what your supervisor can do to relieve you of some of those duties so that you can fit a reasonable amount of work into a day. Meditation is good. Humor is always good. If you can laugh about stuff, it helps. I know you have to do that at appropriate times, but boy, without a sense of humor, I don't know how you'd survive in this field. I think you have to look for that. And exercise. Believe it or not, it can be fun. We have to take our own advice sometimes, and the things we tell our clients are great. Sometimes we have to do those things ourselves. So the interventions in stress management are meant to block a stressor from resulting in the first place, and then mitigate the negative consequences such as illness or disease. Again, serious health conditions can develop from stress. A lot of research around that. And again, I think this is sort of recapping what was just said, but let me see if I missed anything real quick. Too little, kind of an interesting comment, too little occupational stress is almost as unhealthy as too much. I'll let you think about that, but I see the wisdom in that myself. Ceremonies like sweat lodge, baptism, weddings can be an important aspect. Bringing in any sort of spiritual components to your life that would help just relieve the day-to-day sorts of stress tension. It depends on your beliefs and your cultural beliefs as well as your personal beliefs about that. But I think finding something outside of yourself that you can do or think about or meditate on is oftentimes helpful. I don't know if volunteering is a good suggestion if you're already stressed and burned out, but it's listed here. And again, just more methods of how to work with stress when you start to feel it. It's becoming a factor in your professional development. Lots of stuff on stress. I'm going to skip this one. There was a couple of things that I didn't mention throughout this presentation, one of which I think is important at least to touch on, around knowledge, skills, and attitudes. And I think that is being well informed about the direction this field is going, really becoming an expert on evidence-based approaches, looking at the methodology that showed those approaches were empirically supported in some way, understanding the overall vision of behavioral health and where it's going right now, because it's much different than what it has been historically. And again, we're looking at the whole person care instead of individually looking at problems. We're looking at long-term care instead of time-sensitive treatment interventions like 30-day programs, 60-day programs. But we're looking at this disease of addiction more broadly, more as a disease, a chronic illness. And how would you manage other chronic illnesses like diabetes or heart disease? Those things too require behavior change, but they also require ongoing monitoring. They require the help of medical professionals. They require a variety of different professions involved sometimes to help us manage the illness. And I think we have to look at it from this point of view. It's a long-term sometimes disease that requires intervention from a variety of sources at different intensities, and we have to match the service with what the client needs and what the client wants. Any assets in the client's environment that we can bring into the picture helps with that. Focusing on hope and focusing on strengths that the client already has is much more, in my mind, beneficial than focusing on the problems that got them to your office in the first place. Working in a detox center, it's pretty obvious to the client why they're here. I don't think we need to beat them over the head with the fact that maybe they have an alcohol or other drug problem. I think rather than doing that, what we should focus on is what kinds of things would help improve your life situation right now? What kinds of things could we offer or could we steer you towards that might help you with the things that you find are realistic and important to your health, to improving your situation or your health? And really start there. Start where the client's at. Help them sort through the complicated array of problems that they might present with and say, well, what do you have going for you? What kinds of things do you think you already possess that we could build on? And instead of focusing on the problems, recognizing that this is a long-term, oftentimes long-term illness, recognizing that mental health and substance use disorders are often co-occurring, and recognizing that physical pain and other kinds of physical problems coexist with mental health and substance use disorders. So it's a very complicated pattern of issues that we have to sort out, help the client sort out, and find their strengths and find their ways in their own world of working through some of these things. As a clinician, I think the professional relationship helps to open doors to a variety of options for people. Recognizing our own limits in terms of professional knowledge and skills, recognizing when it's best to call somebody else and bring them into the picture if we can, and paying attention to our own well-being. All of those things play into it. But again, looking at the field and saying, where's the latest research in the field, and what are the best and promising practices currently out there that we should know more about and we should utilize and help the field move forward. It's our responsibility not just to treat clients, but help the field evolve. And then quickly, I just want to touch on confidentiality and really being aware of confidentiality laws. This kind of ties in with ethics, but being aware of the confidentiality law 42 CFR Part 2 that specifically targets substance abuse treatment providers who receive any kind of federal funding. Those confidentiality laws are very strict. They're very limiting in terms of what we can reveal to outside parties, and they need to be understood by anyone working in this field so that we don't reveal client information that we shouldn't reveal to whether it be law enforcement, the courts, or whoever without the client's consent. To me, that's not just a legal issue, but it's a mandatory ethical issue that we protect a client's confidentiality. Because, unfortunately, stigma still impacts a person, can impact a person's life if it's discovered that they're in a treatment facility. And we certainly don't want to discourage people from getting help because we can't protect their confidentiality. And just to reiterate, supervision is key, and being aware, again, of your own health and well-being in order to better serve your client. And that's really all I had today. I know this is sort of broad in a general overview of very complex topics that deserve much more time, but I hope it was a little bit helpful, and I hope it was a little bit insightful. And at this point, I'll take any questions if Karen wants to take over.
Right. Thank you, Bob. Yes, so if you have any questions, please go ahead and type those in that question chat box at this time, and I'll go ahead and pass those along to Bob. So our first question is, do you have any tips for handling conflict with a supervisor?
Yes. If you can't resolve a problem with your immediate supervisor, if you absolutely can't, then my advice is to go to the next person on the table of organization for wherever you work, the next level, and just have a professional discussion about why you have a difference of opinion or why you have a disagreement with the supervisor. My advice would be, though, is to have something prepared before you do that, something that clearly shows what the disagreement is about or what the problem is about, so that when you go into your supervisor's office, you have something to show them and say, look, I've tried these things, they didn't work, here's the issue. But don't go in with any sort of emotional reaction that says, I hate my supervisor, she's a jerk, or whatever the case might be. You have to have something to back it up. They're going to be looking for that. But that would be my general advice.
Thanks. Our next question is, in helping to relieve staff stress or burnout, how helpful is it to offer better remuneration? I find that it can hurt at times.
Well, that's always an issue, and there have been a lot of studies done to show that higher pay doesn't equal higher satisfaction with a job. That sounds counterintuitive, but it's been shown to be the case. I think the more valuable outcome would be to have people invested in their jobs and in the work that they do. In other words, the counseling staff believes in what they're doing and they're excited about it. And if you can get that to happen, if you can get that level of enthusiasm present in your facility, then pay becomes much less of an option. Now, having said that, on the other hand, I think professionals in this field should be paid as well as professionals in other healthcare fields like medicine or mental health. I think there's often a disparity between substance use counselors or chemical dependency counselors and mental health professionals, and I think there needs to be parity there. So I think we should be rewarded. We should be rewarded for doing the work that we do, but to just expect satisfaction from staff by paying them more, I think is a misnomer, because I don't think that results in happier staff. I think it results in better paid, unhappy staff.
All right, our next question is, what are your thoughts about certain levels and types of self-disclosure when working with cultures that may respond favorably to treatment when self-disclosure is made?
That's a really good question. I did some work in Hawaii for about 3 years, and I found the Hawaiian culture was much different with that respect to that self-disclosure or knowing the counselor more personally was very critical to developing any sort of professional relationship. And adjustments have to be made based on that. I think understanding the culture or understanding the population that you're working with and what their expectation is important, and it's going to vary from culture to culture. So I've had people from people from the Midwest, say, who have come to me as a counselor and have said, you know, I don't want somebody that's in recovery. I want somebody that's never had this problem to tell me how to live differently. And then I've had people say, you know, if you don't understand my problem, how are you going to help me? So it depends on that as well. But from a cultural perspective, you have to make adjustments to the culture and the expectations of that culture for what it means to enter into a relationship like this. In Hawaii, I ended up adjusting my style a little bit, not to talk about myself all the time, but to make some connection between my personal my personal life in some sort of almost abstract way, but a way that let them know I was sharing something personal about myself, and it put them more at ease oftentimes and allowed them then to feel more comfortable sharing with me. I think it comes down to an organizational decision now, and I think if it's a question for you in your organization, you should talk it over with your supervisor. But I think adjustments have to be made based on culture.
Thank you. Our next question is, with EBPs, do you provide cultural competence, with EBPs, how do you provide cultural competence services when the EBPs are for non-native populations?
What we did when I was with the, at the time, Prairie Lands Addiction Technology Transfer Center, working with Karen, was we got together some tribal representatives, tribal leaders, and we said, here are some Western-based approaches to working with clients. How do we adapt them to various Native American cultures that exist, or American Indian, Alaska Native cultures? And what we did was we got these tribal leaders and tribal representatives, usually on a conference call, but sometimes in person. And we just asked them the questions. Here's the Western-based approach. How do we adapt it to better fit Native American beliefs? And we did that. The thing we focused on in doing that was the TAP 21A for clinical supervision. And we were looking at ways to adapt a Western-based notion of clinical supervision to a Native American model of clinical supervision. And there were all kinds of things that came up as a result of that, using imagery, using stories as a way to get clinical supervision messages across. There was a variety of things that we actually developed an addendum to TAP 21A based on that. The other things that have been done so far is motivational interviewing. I think it was in New Mexico, a Navajo-based model of motivational interviewing was developed based on Navajo culture and adapted to Native American culture. The sad answer to your question is it's not being done enough, but I think that effort is being made with Native Americans primarily through the ATTC to find ways to adapt these Western-based notions of health to Native American cultural beliefs and systems of care. It's a slow process and it's not happening fast enough. But the only way to do it correctly is to involve the people whose culture we're talking about and have them be the experts on how to do this. As a white guy from Iowa, I'm certainly not going to sit down and say, well, here's the best way to do it. It has to come from the culture itself. It's probably not a very good answer.
Thank you. Our next question is, what percentage of clients in your facility are dealing with co-occurring issues? 50%, 75%?
Oh, just a rough estimate, I would say 75%. We get people with very, very complex mental health, substance use, physical health problems, and it's all combined. It's a very complex health care scenario, and I would say at least 75% of our clients have some sort of co-occurring disorder. That's pretty safe to say.
Thank you. Our next question is, who will be a better counselor, a person in recovery or a person who has never abused substances?
Either could be a better counselor. I think the two benefits are that somebody who's never been in recovery can be more objective and see things that maybe, without using their own experience to, what's the word I'm looking for, to bias their approach. That can be a benefit for somebody who's not in recovery. For somebody in recovery, there can be a much more intimate understanding of what the person you're working with is going through. So either counselor scenario could benefit the client more. I think if it's you and you're not sure, I think you ask your supervisor, how important is this for this particular client, and should I reveal whether or not I'm in recovery? Would that help them or would it not help them? Usually, and this has been something that I've seen happen over the years, if you ask clients in a group setting, if you ask them, if you were to do this, ask them which counselors they thought were in recovery and which ones they thought weren't, they'll usually not get it right. They won't know if you're not revealing that, obviously. They don't know. And I think to avoid that whole issue, sometimes it's best just to say, I personally just don't talk about that with the people I work with, but I think I can help you. So let's see if I can be helpful.
Thanks. Our next question is, as a counselor, would it be a good idea for the counselor to take time off from work to prevent burnout?
I think if you're faced with taking time off versus burnout, I think you have to talk that over with your supervisor. And I mean, if those are the options, if you're at that point, then obviously it's a better solution to take a break, a leave of absence, or whatever the case may be, to avoid getting to a point where your health is in jeopardy. Personally, I think, and in experience as well, I think that's always the decision. We have to take care of the people that work for us and with us, as well as the clients.
Thank you. Our next question is, what tools are available for self-evaluation, and are there any cultural specific tools?
I'm not aware of any offhand. I know there's some out there, but I'm not aware of any that I could reference. I'd have to do some research to find those. I don't know about culture. I would imagine the same thing is true for different cultures, but again, I don't know without checking.
All right. That is all the questions we've received so far. So if anyone has any additional questions, you can go ahead and type them in now. We have time for a few more. Well, if we don't have any additional questions, then I think we can go ahead and start wrapping this up. So thank you once again, Bob, for sharing your expertise and knowledge with us today. We really do appreciate it. And yeah. Thank you. Please watch for our email with handouts for this webinar. Attachments will include your CEU request form and the PowerPoint handout, and there will also be included a link to our customer satisfaction survey. We do appreciate your decision to complete our survey, as completion of these surveys allows us to show SAMHSA the number of people served by our webinar. To participate in the GIPR evaluation, you'll just click on the link in the email and it'll take you right to the survey, and you can fill that out and submit it for us. We hope you'll be able to join us for our next webinar in this series, Group Counseling, on Wednesday, October 16th. And we also hope that you'll be able to join us for our next webinar in our American Indian and Alaska Native Behavioral Health webinar series on October 2nd, where Dr. Peter Nathan will present From DSM-4 to DSM-5, Significant Changes for Substance Abuse Professionals. And finally, we'd like to thank all of you for your time participating in today's session. We hope you enjoyed the session, and we look forward to hearing your feedback. So thank you.